Welcome to today's program, Nighttime Blood Pressure in Daily Practice. My name is Professor Francesco Cappuccio. I'm a chair of cardiovascular medicine at the University of Warwick in Coventry, United Kingdom. And I have the pleasure of being joined today by Professor Danny Shores from University Hospital Brussels. Welcome, Danny.
Thank you.
And before we start today's session, I have some housekeeping and really take you through the agenda in the first place. After this very brief welcoming introduction, we'll have two presentations. One, I will lead on circadian patterns, sleep apnea, and non-dipping blood pressures. And the next one, led by Professor Shores, on how easy is it to use a home blood pressure monitoring during the night. Now, I want to highlight there will be plenty of time for questions and answers. So remember to submit your questions in the Q&A box, which you will find below in your screen. And we'll try to answer every single one, or if we are short of time, we'll try to put together the ones that are common topics. Before we start in the next slide, I will just list here the learning objectives for the day. I'm not going through all those, but these will be covered in the two talks. And if there's anything that you don't see, please do ask. We would be very happy to fill any gaps that you might find. Just a reminder, these sessions has been created by Radcliffe Cardiology, and it is supported by Omron Healthcare. And without any delay, I'll start beginning my presentations for you. What is circadian patterns, sleep apnea, and non-dipping blood pressure? What is the connection? And this is just an introduction to the topic that will become more clinical later on. So first of all, I want to introduce you to the basic components of the circadian rhythm. The control of our sleep-wake cycle is placed in the suprachiasmatic nucleus of the hypothalamus. It is made of a few numbers of highly specialized cells identified as the circadian pacemaker, sometimes known as the body clock. This body clock, which similar to what happens in the heart with the heart rate, it controls the timing of most of our 24-hour behavioral and physiological rhythms, including the sleep-wake cycle, alertness, performance, hormone production, temperature regulation, and metabolism. Biological clocks have the ability to oscillate in a self-sustained manner, in the same way as a heart kicks your heart rate, and to sustain biological rhythms through some output pathways that you can see in the screen there, reaching out to organs and tissues peripheral to the hypothalamus. In addition to the central body clock, that sometimes we refer to as a master clock, there are several peripheral clocks, sometimes referred to as slave clocks. And those are situated in every single organ, tissue, and in most cells. These clocks are synchronized to the solar day, so to the light, through some input pathways that you see here. And the synchronization to the light-dark cycle happens through direct neuronal projection from the retina to the suprachiasmatic nucleus. A desynchrony of a misalignment between the biological clock and the circadian rhythms, and this is very often happens in shift workers or in other non-24-hour disorders, if they are sustained over a long period of time, lead to a variety of health problems. You can see listed on the right-hand side here. And the biological consequences can be immediate, like attentional failures, for instance, or could be long-term and will involve both neurobehavioral mechanisms, like reduced alertness, impaired cognitive function, or lower mood sometimes, but also physiological mechanisms like high blood pressure, glucose intolerance, insulin resistance, weight gain, reduced immune response. And these will have long-term morbidity and mortality implications, particularly for chronic diseases as well. So in summary, in this little introduction, a day-night rhythm is present in every function of the body. And this slide illustrates the complexity of the circadian regulation in every system, organ, and tissue. And I have highlighted here with these arrows, in particular, the circadian variations in blood pressure values, which reach a peak in the late afternoon and the early evening, and show the sharpest rise in the early hours of the morning. This slide shows a 24-hour blood pressure tracing in a patient with hypertension, with high blood pressure. The monitors measuring a 24-hour monitor are typically programmed to take readings every 30 minutes throughout the day and either 30 or 60 minutes at night. Whether it's a normal or hypertensive patient, we would usually expect to detect a nocturnal dip in the blood pressure. This nocturnal fall in blood pressure is usually attributed to a decline in the sympathetic nervous system activity, which is associated with sleep, rest, and supine position. Indeed, also heart rate falls at night, as we probably know. However, not always do we find this nocturnal pattern. If we don't find that, we may find that the expected nocturnal dip in blood pressure that is depicted in the black tracer can be replaced by an absence of it, as in the red tracer. And we refer to this as non-dipping. Or else we can observe a paradoxical phenomenon of a rise in nocturnal blood pressure that we refer to as reverse dipping. So in summary, blood pressure variations over the 24-hour period follows a pattern with a peak in the early morning, the morning surge, and a decrease at night, which is the dipping. The morning surge is caused by a variety of mechanisms, as indicated in the pink box there. Some are very physiological, some could be not physiological. The nocturnal dipping is normally defined as a fall in blood pressure over 10% of the daytime blood pressure. But in some cases, it could be extreme dipping when exceeds 20% drop in blood pressure at night. On the other hand, as we have seen earlier, that fall could be blunted. So we have what we call a non-dipper individual, or even an inverted pattern at night, which characterize the rise or the revert dipping due to a variety of mechanisms. And those are indicated in the blue box on the left-hand side here. In some circumstances, like in the red thing, there is also a nocturnal surge that can occur for a number of reasons that we can see, we can touch upon a bit later on. So these variations of this pattern are mainly due is a result of two phenomena. One is the described endogenous circadian rhythm regulated by your body clock, which exerts its peak in the evening hours. But also there are superimposed on the circadian pattern the behavioral effects, which will determine changes in blood pressure. So the blood pressure starts declining from late evening onwards, reaches a nadir around midnight, and rises just after awakening in the morning. Now, traditionally, blood pressure thresholds and targets clinically have been set using daytime office blood pressure measurements to inform clinical guidelines. The introduction of 24-hour blood pressure monitoring in clinical practice has allowed us to redefine the hypertension definitions using daytime blood pressures average over a 24-hour period. Comparing the classifications of hypertension using the daytime blood pressure with the two methods in the same individuals will help identify 4 distinct clinical groups. We have the true normotensives, the green group, and these are the individuals whose blood pressure outside, in the office and in 24-hour daytime are concordant below the thresholds for normotension. The true hypertensives, on the other hand, are those which have concordant readings of the two methods, but on the upper level of thresholds for hypertension. And then we can define two additional groups: the white coat hypertension, where the blood pressure outside in the office is high, but outside the office is normal, either with 24-hour blood pressure monitoring, or in clinical guidelines, we can approximate using home blood pressure readings. And the other group is the so-called masked hypertensives here. Those are the individuals difficult to pick up, who have normal blood pressure in the clinic or outside or in the office, but when they run the 24-hour monitoring, their blood pressure is above target. And the prognostic importance of these four groups is shown in the next slide. The risk of developing cardiovascular events here increases from normotensive group to white coat through masked and hypertension. And the prognostic value of daytime average 24-hour blood pressure appears to be superior to the prognostic value of the daytime blood pressure measured in the office. Hence, the new guidelines require now confirmation of the diagnosis of hypertension with an out-of-office blood pressure readings, which will be obtained either by running a 24-hour ambulatory blood pressure monitoring device, or in alternative for primary care, a home blood pressure readings run with a specific protocol of several readings throughout the day. But why should we then be interested in nocturnal blood pressure? And should we need to measure blood pressure during sleep at all? Let me just try to address this. The prospective follow-up studies are in agreement to show that the best predictor of future cardiovascular events is the average nocturnal blood pressure, both for systolic and diastolic pressures. And these are studies carried out prospectively in large group of patients having undergone 24-hour blood pressure monitoring. And the latest position paper of the European Society of Hypertension acknowledges that there is a compelling evidence that nocturnal blood pressure is superior to casual office blood pressure in predicting outcomes. And furthermore, an increase in nighttime blood pressure may indicate the occurrence of a number of associated pathological conditions, one of the commonest being obstructive sleep apnea. Obstructive sleep apnea is a chronic condition which is frequently associated with hypertension and with high nocturnal blood pressure. Obstructive sleep apnea is a sleep disorder which is characterized by frequent episodes of partial or complete collapse of the upper airway during sleep. These obstructions cause cessations of airflow, disturbances in gas exchange with hypoxia, frequent arousals, and often snoring. The snoring is not present in 50% of the cases, so it's a good guidance if it's present, but it's not to rule out if it's not present. During these episodes, the patients experience recurrent cycles of oxygen desaturation, sympathetic overactivity, and metabolic effects. And these recurrent cycles of oxygen desaturation cause sleep fragmentation, restless sleep and frequent arousals, fatigue, excessive daytime sleepiness, poor concentration, reduced performance, attentional failures, and these are all risks for road traffic accidents and overall reduced quality of life. At the same time, obstructive sleep apnea activates a variety of mechanisms like sympathetic overactivity, metabolic effects, endothelial dysfunction and inflammation, causing high nocturnal blood pressure. And non-dipping is very common, and reverse dipping is also quite often seen. We also have nocturia, night sweats, glucose intolerance, insulin resistance, weight gain, diabetes. So all these together would not surprise you if I tell you that in the long term, if it's not adequately treated, obstructive sleep apnea is one of the most important risk factors for the development of cardiovascular disease, going from hypertension, arrhythmias, sudden death, myocardial ischemia, stroke, or heart failure. It's a very important and very often undetected condition unless it becomes very severe. The presence, indeed, the sleep apnea syndrome is a strong and graded risk for developing hypertension. As you can see in this slide on the left-hand side, if we go for no sleep apnea, mild, moderate to severe, the incidence of hypertension increases with the severity of the respiratory disease, which in this particular case is measured by the apnea-hypopnea index, reporting the average number of apneas per hour. And in moderate to severe obstructive sleep apnea, the incidence of hypertension may reach 70 to 90% after 15 years of follow-up. Likewise, there is a strong and graded relationship between presence and severity of sleep apnea and the risk of death in general and cardiovascular death in particular. Recently, a panel of experts have summarized the main factors associated with diurnal variations in blood pressure. And for nocturnal hypertension in yellow, there are close correlates identified either as determinants or as consequences of it. They are seen in the yellow box, and the list here is not comprehensive. And in the next slide, I list some common conditions associated with nocturnal hypertension and the associated mechanisms that might be involved. Just to give you an idea of how important, how common it is, this nocturnal rise in blood pressure, which is associated with an increased risk of cardiovascular disease, at the moment is not considered at all in diagnostic and management. They involve several organs and systems, as you can see, from respiratory to cardiometabolic, renal, and there are also behavioral systems. I've just listed here the sleep and nutrition areas. The mechanisms likely to contribute to a sustained rise in blood pressure at night are activation of the sympathetic nervous system, and you can find the symptoms related to that being like nocturia or an increase in heart rate. Sleep disturbances, they can go from insomnia to frequent arousals leading to also sleep fragmentation and snoring, which keeps you waking up all the time. Also salt sensitivity by favoring fluid retention, polyuria and nocturia can contribute to rising blood pressure. But also there are other effects which are less visible at the naked eye, like endothelial dysfunction, inflammation, and an increase in arterial stiffness. And this is just a limited list of mechanisms which are involved in the contribution to nocturnal hypertension. Before I close, I just want to touch one final point, and that is we must briefly address the recurrent question, which does it matter at what time we prescribe antihypertensive medications? We have seen so far that high nocturnal blood pressure is more closely associated with fatal and non-fatal cardiovascular events than is daytime ambulatory blood pressure. However, the 24-hour ambulatory blood pressure monitoring may cause sleep disturbances in its own right in many patients, as we'll hear later on by Professor Shores, and this is a poor reproducibility within individuals. Current guidelines provide guidance based on the benefits seen in treating daytime blood pressure with drugs, usually given in the morning. There's no indication based on nocturnal blood pressure, so we have no idea whether it's beneficial or not. And the question that is not answered yet fully is, does lowering high nocturnal blood pressure, giving antihypertensive medication in the evening, reduce the risk of events more than lowering daytime blood pressure by giving tablets in the morning? Now, the answer can only come from a well-conducted large randomized trial of long duration. And there is a recent study that's been published that created some controversy following an early study that administering blood pressure medications that in the evening would restore and reduce the blood pressure variability The same Spanish group went on to design a trial on outcomes, including 19,000 patients, the so-called IGIA trial, which reported controversially that the group of patients who were given tablets before going to bed had a greater blood pressure, average blood pressure reduction with 24-hour monitoring by 3.3 over 1.6 millimeter of mercury compared to those being dosed in the morning. But there was no difference in daytime blood pressure. And that's the first controversial issue. Surprisingly, though, for that tiny difference in nocturnal blood pressure, they detected a change in cardiovascular events over 6 years, a further reduction of 50%, which doesn't tally with the small change in blood pressure at night for what we know. So the study had several flaws that were highlighted in design, analysis, and reporting. And although that's been confirmed, it's the only study available at the moment. However, there were some doubts raised, as I said, not only to methodology, but to the ethics. And in the meantime, another very large trial has seen its completion, the TIME study, in 21,000 hypertensives. This is run in the United Kingdom. And the results are being analyzed as I speak. And I think we eagerly await the results of this other trial to try and see whether there's anything that would suggest that we might change the pattern of blood pressure administration, at least in those with estimated nocturnal hypertension. So for the time being, I think the recommendations internationally remain to administer blood pressure medications in the morning. So to conclude in summary, blood pressure follows the circadian pattern. Based on 24-hour ambulatory blood pressure monitoring with hypertension, people with hypertension can be characterized by their patterns in white coat, masked, dipper, non-dipper, or reverse dippers. Nocturnal blood pressure is a stronger predictor of cardiovascular morbidity and mortality than daytime blood pressure. And finally, high nocturnal blood pressure is common in several conditions, and it may have important prognostic and therapeutic implications. So I thank you for listening to me now, and being moderator, I pass on to Professor Schurz directly the microphone for the second part. Now I'll come back handling the questions and answers. Please, Professor Schurz.
Thank you, Francesco. I will focus on the nocturnal blood pressure measurements, and I will focus on a new device made by a company of Omron, which is a wrist device, and I will guide you to these results I had with some patients. Now, for the nocturnal blood measurements, we normally use the 24-hour blood pressure ambulatory classic machine. We all know this machine. It measures blood pressures during the day every 15 minutes and measures it during the night every 20 or every 30 minutes. The advantage of this classic ambulatory blood pressure device is that it's a validated technique. And it gives you a bulk of data. We have a lot of data because we have measurements every 15 minutes during the day and every 30 minutes during the night. So it gives us, at a whole, after 24 hours, about 60 to 80 measurements for the whole day. And the advantage is that you have measurements during day and night. Now, every device has an advantage and also has a disadvantage. Now, what I hear of my patients, which is a disadvantage, is that it measures your blood pressure every 50 minutes, which is quite a lot and can be disturbing for the patient. Now, some patients complain about measurements during the day, but a lot of patients complain about the measurements during the night, giving them sleep disturbance, either due to the fact that it measures your blood pressure every 30 minutes and also by the noise of the device. A further disadvantage is that it measures your blood pressure only for 1 day. You can keep the machine for 2 days, but mostly we do it for 1 day. And this is then the data of only 1 day. Now, I'm a cardiologist. I also look at heart rate, and I know that the use of a Holter registration for heart rate for 1 day doesn't give you all data of the patient, because not every rhythm disturbance you will see on 1 day. Now we will look at this newer device. So this is the small Omron device put on the wrist of the patient. It's a small device, and you can measure with this device yourself during the day. So you push on a button and it measures your blood pressure like a home blood pressure registration. During the night, you can push on the night button, and then this device will automated gives you 3 readings. That is the first reading 2 hours when you go to sleep. At 2 o'clock in the night, it says 4 o'clock in the night, and it gives a third reading 4 hours after you pushed the night button. So you will have 3 automated night readings. The possible advantage of this device is that you can give the device to the patient for 1 day, but you can also give this device to the patient for 1 week. So you will have several readings for more than 1 day. And the possible advantage of this device is that it will give less disturbances during the night, because it doesn't make any noise, and the measurement is quite non-disturbing. That should be the advantage of this device. Now, this is what the company says, so we tested it. So I did a trial at my hospital, looking at the feasibility of this device in several patients, and I used patients with and without a history of hypertension. I gave them the device for 1 week to do measurements for 1 week, and I asked them to put on the device every evening, so to measure blood pressure during the night, 3 times during the night, like I told you, at 2 a.m., 4 a.m., and 4 hours after they went to sleep. And they could also measure blood pressure during the day, but they have to do it themselves. And I asked them to do it between 3 to 5 times during the day. I included in this study, in total, 38 patients. Most of them were male, so 22 males, 16 females. And the mean age of these patients was around 62 years old. Of these 38 patients, about 20 of them had a known diagnosis of hypertension. They were not all treated with antihypertensive drugs. 18 of them were treated with antihypertensive drug. 29 of them had a family history of hypertension. And a lot of these patients already had a blood pressure device at home to do blood pressure home registration. It's about 30 of these 38 patients. Now, in the previous talk, you heard that there is a relationship between nocturnal hypertension and also sleep apnea. So we asked the patients, these 38 patients, if they had a known diagnosis of sleep apnea, and there were just a few, 4 of them, who had a known diagnosis of sleep apnea and were treated by this, all by night CPAP. So the very few of the patients had a known history of sleep apnea. I will not focus this time on the blood pressure data with this night view device, but I asked the patient to wear the device for 1 week. They don't need all use the device for 1 week. Some of them had it only for a few days, and the patient who took it the longest was 10 days. So there were data which have between 4 and 10 days. The mean time they used it was 6.6 days. And we had lots of amounts of data. most of the time it was around 40 to 50 values we had in these 6 days. Most of the data comes from daytime measurements because the patient pushed on the button between 3 to 4 times a day. And we also had about 3 night data. This for 1 week. We can later on focus on the data of this device. Now, I correlated with the blood pressure you measure during the day, and there's a clear correlation between this device and the measurements you do yourself. There's also a clear relation between these data and the home blood pressure registration. And I also correlated in some patients with a classic 24-hour device, and there is a clear correlation between these data and the one with a classic 24-hour device. On this talk, I will mainly focus on the feasibility and the easy in use of this device. So I asked the patients, after they wore the device for 1 week, to fill in a questionnaire. And in this questionnaire, I asked them about their experience with the device and to grade the experience from 1 to 5, 1 meaning it's a shitty device, 5, it's a very good device. And I asked them about comfort of sleep, comfort during the sleep. Another question was about comfort during the daytime measurements. And the third question about the easy in use of the device. All patients, all 32, rated these all 3 questions, so the comfort during the sleep, the comfort during the daytime measurements, and the easy in use, all graded them between 4 and 5. So all graded the device as an easy in use, very comfortable device. Also, one question was, did you woke up during the night due to this night view device? Only 1 of the 38 patients said he woke up during the night due to the device when he used the device for 1 week. More patients said that they had the impression that the device did not work properly during the night because they didn't feel anything at all. But when I then later on confronted them with the results, the device clearly had worked 3 times during the night, but the patient didn't feel anything of the device. No, they didn't feel the measurement of the blood pressure at all. So they didn't wake up at all. And some of the patients really said, I think the device didn't work at all. So it was very comfortable to sleep. So about this device, I think we can conclude that from these 38 patients, this Omron night view device is easy in use. It's like a classic home blood pressure registration. It's well tolerated during the night, which is very important because certainly I have some patients who had this device and used the classic 24-hour blood pressure registration, which was certainly in most of these patients not well tolerated because they woke up a lot during the night. And if you wake up a lot during the night, you can have some doubts about the night measurements, if they're really sleep measurements. And telling this, most of my patients said this device was better tolerated than the classic 24-hour ambulatory blood measure device. And I think this is my last slide, so we can now return back to Professor Cappuccio.
Well, thank you very much, Danny. That's a very clear presentation of the advantages of this new device compared to ABPM. So I will remind you all now that you can put your question through the Q&A box at the bottom of your screen, and I'll try to address them. So we already have a few questions coming in. So Danny, if it's okay, I can try to distribute questions between yourself and myself and try to address all of them. For instance, there is one thing I want to ask Danny, maybe if you have experience. Somebody is asking in regards to nocturnal hypertension in relation to CPAP use in patients with sleep apnea syndrome. How many times would it be needed to take nighttime measurements?
How many times?
How many times?
Well, I don't have all data of my 38 patients, but I have some data about they use the device for 7 days, and I only have 3 readings during the night. But if I compare these 3 readings during the night and I compare them with a classic 24-hour blood pressure station, then you have about readings of each half an hour, so you will have about 10 to 20 readings during the night. But these are very comparable. So the results of 3 readings are very comparable with the 20 readings during the night. Now, something which I have seen in the data I have in my patients, that in the 7 days registration, not every night is the same. So I have also variations in the night registration of blood pressure based on 3 measurements during each night. But I clearly see that in the 7 days registration, there seems to be some variation. So not every night is the same night.
Yeah, and you had 4 patients with sleep apnea. Any specific information you might have in experience in those with sleep apnea, and whether they were taking CPAP or not?
They were all treated with CPAP, all 4 of them. So these were my known patients with sleep apnea. In the 38 patients I had about 1/3 of them who had nocturnal hypertension.
Right. Okay.
And I have sent these patients for a sleep test.
Yeah. Okay. So it is still early days. This is one of the very first few studies that are happening with this device. Yeah. Now, there are a few more questions I think I'll try to address. First of all, the one easy one, what is considered a normal blood pressure value at night? I can answer that straight away. So the European Society of Cardiology and European Society of Hypertension guidelines define nocturnal hypertension as a blood pressure with 24-hour monitoring above 120 and or 70 millimeters of mercury. The American guidelines, however, they are a bit more strict to 110/65. But remember, for those who are familiar with the 2 guidelines, the American guidelines have a slightly different scenario with all the targets are slightly lower because they use a different unattended blood pressure measuring. So in Europe, we use 120/70 as a target, as a measure. Now, the other question is, which I think I answered in my question, is nocturnal blood pressure more important to manage than during the day? The jury is still out on that. One study suggested it might be important in those who have high blood pressure at night to give tablets in the evening. The other study is coming up. So the answer at the moment, we don't know. Danny, one question for you. To which patients would you recommend the use of this device in the first place? Do you have any specific indications that might be additional benefits? I suspect those who might have more likely to have nocturnal hypertension, I suppose.
Well, it's from a clinical point of view, if you have a patient which you suspect from sleep apnea, I will certainly do a 24-hour registration with a classic one or with this new device. As a cardiologist, I have lots of patients with left ventricular hypertrophy, and also left ventricular hypertrophy means that your blood pressure is probably not well controlled. And even if the blood pressure is good controlled during the day, left ventricular hypertrophy probably means that blood pressure is too high during the night. So hypertrophy, either on an ECG or an echo, which is a better technique, is certainly a reason to measure blood pressure during the night. I think we have an underdiagnosis of nocturnal hypertension in a lot of patients with diabetes.
Yeah.
I see a lot of patients with diabetes, and often they're not enough control of blood pressure. And patients with diabetes are also, for me, high-risk patients.
Yeah. Yeah, if I can add to that for the audience who might have an interest across the different specialties, as you know, hypertension sits in between so many specialties, from cardiology to renal medicine, to endocrinology, to general medicine. And then we have now obviously neurologists, stroke physicians. So it's fascinating how this hypertension is almost at the center of many specialties. That diabetes, particularly type 2 diabetes, we know has a higher prevalence of nocturnal hypertension, and we got data, and I showed us some mechanisms. The intriguing thing is the mechanisms involved, because one obviously is an activation of sympathetic nervous activity at night, but also there are other aspects like salt sensitivity and fluid retention, which will make diabetics more sensitive to it. There is increased inflammation in diabetes, whether or not with obesity, which makes them more at risk of episodes of cardiovascular effects. And the aortic stiffness, or the large artery stiffness that comes after long-term diabetes, seems also to be a component that will lead to nocturnal hypertension, which in those cases, we haven't mentioned it, but is isolated systolic nocturnal hypertension, which you find also in older age. So I think the stiffening of the arteries and the aging of the arterial bed, particularly the large arteries, which is present with old age and in type 2 diabetes, seems to be one component of driving the nocturnal high blood pressure. I have more questions here. I'm trying to address it one at a time. Let me see. All right, Danny, one for you. How many nights should patients measure in order to detect nocturnal hypertension at the patient level?
Yeah, if you use a classical device, it's just one night, but I think using the device now in these 38 patients, I'm more and more convinced that you should measure it more than one night. And giving the device for 1 week gives you lots of information. And I think you better have more the more data you have from the more days you measure. I think 1 week is a very good time schedule.
Yeah. I would add that for those clinically, at the moment we rely on defining hypertension with 24-hour monitoring on 1 day measures, as you say. Now there is clear evidence already, and there is a position paper of the ESH, which demonstrates quite clearly through a large meta-analysis that the lack of reproducibility of the classification of hypertension by 24-hour monitoring in an individual. In other words, if you have your 24-hour monitor done today, and you do it, and you are a white coat, and you repeat it in a month, is very poor reproducibility of your white coat definition. And that poses a big questions when you base your decision to whether to treat and how to treat on the basis of a single day. So in a sense, although you got lots of data for the characterizing an individual at that point in time, for instance, one plus of this new device would be that you could rely your definition on several days that will average the position where maybe other effects that might affect your variability in your blood pressure. So variability is as important as the single value or the average. I think you made a point in your presentation, Danny. So I think that is a sort of extended answer to the question.
Yeah.
Right, there is one question I'll try to answer. Is there a standard effect of antihypertensive medication across daytime and nocturnal hypertension? Or do some medications work better in day versus night and vice versa? Now, I think I'll try to answer this different layers. First of all, any effect on blood pressure depends on the duration of action of the drug in terms of diurnal effect. So most antihypertensive medications we use now are long-acting, but only 1 or 2 last for 24 hours. So the other question is, if you give it at night, it will have a maximum effect at night in the early morning, but may wear off in late afternoon when you're up and about. And if you take it in the morning, it may wear off at night when you want to. So I think there is no clear magic bullet, and there is no particular tablet that is more effective than others. From the 1 or 2 studies that we've seen, the EGA trial, for instance, in that where they swapped, it is clear that the type of drug you take is more gives more or less side effects at night, because if you give tablets at night, like they did in the EGA trial, in a group randomized to night, one of the problems was the self-selection bias. A third of patients stopped taking diuretics. They swapped to another drug. So the 2 groups were unevenly distributed in terms of type of drugs they were using, because if you take a diuretic before going to bed, you get up several times a night. And rather than lowering blood pressure with the diuretic, you raise your nocturnal blood pressure for the frequent interruptions of your night. So in more than a third of cases, patients voluntarily changed from diuretics to another drug. So the question is complicated, but there is no physiological knowledge or mechanism by which a drug should be more effective at night than during the day. Right. Okay, Danny, is it nocturnal blood pressure monitoring a good tool for diagnosing underlying causes of nocturnal hypertension, or only a tool to monitor sleep apnea patients' nocturnal blood pressure? Probably we have answered in part earlier. You said that LVH, type 2 diabetes, you want to expand on that. This obviously is a tool that should be expanded to as many at-risk patients, isn't it? Do you agree?
I agree, yeah.
Yeah, okay. Right, what proportion of hypertensive patients do you see have nocturnal hypertension?
In the patient I have seen, these 38, 1/3 had nocturnal hypertension, 1 in 3. So it's quite a lot.
Yeah, and that is similar. I think similar to much larger studies with 24-hour ambulatory blood pressure monitoring, which I've seen, which indicates the prevalence of nocturnal hypertension, which varies from country to country, from selection criteria, varies from 30 to 60%. For instance, there's an American study in African Americans where the proportion of people with nocturnal hypertension was much, much higher, was approaching 60%. Yeah. And so even ethnicity might be, obviously there are many confounders in this, but in reality it's probably much, much higher than you would think. And the real question we know is an additional risk. What we don't know is whether to treating it will increase benefits compared to daytime. And that's where the point is that we still don't know in terms of translating the knowledge into practice.
One of the questions I have about the nocturnal hypertension, or the measurement of the diagnosis of nocturnal hypertension with the classic 24-hour devices, are you really to have nocturnal hypertension, or do you have a higher blood pressure during the night because you didn't sleep well during the night? Exactly. And with this device, all my patients except one said they didn't woke up at all. So in this device, I can clearly tell that 1 in 3 had nocturnal hypertension, which was not due to the fact that they didn't sleep, because they all slept well. So indeed, there is a large difference in studies between the incidence of nocturnal hypertension based on the patient selection. Yeah, sure. But I'm really quite convinced that the classic device in large amount of patients disturb their sleep and then maybe misdiagnose or overdiagnose nocturnal hypertension.
Yeah, I agree. That's important. There is another important question, Daniel. I think probably I'll let you start the answer first, I might add. Would you put a patient with nocturnal hypertension with inverse dipping, basically, but with normal blood pressure during daytime on antihypertensive medication?
I would do so. I think you have to look at the bulk of data, and if the mean blood pressure is too high, I would treat this patient too. Also, certainly all patients with reverse hypertension, I will treat them. And maybe I will treat this patient, and this is not based on evidence, but I will treat a patient with a drug on the evening.
Yeah, but would you be afraid of causing hypertension during the day?
I think you have to treat the patient and see what happens with his blood pressure.
Yeah.
I will not start straight away with 2 or 3 drugs, but start with 1 drug in the evening, and but I will treat the patients.
Yeah. Well, the answer to this question, from my point of view, would be that those are the cases where the clinical judgment comes into place. So guidelines don't really answer always, don't give you all the answers for every single patient you see. And this is an area which probably people realize they're listening, that is still quite a lot of research to be done. And the presence of this device is trying to allow us to gain more unbiased data to make decisions, but rather than having already ready-made answers. As Danny, I would probably consider treating or try to find out why there is a reverse dipping in the first place. Yeah. Because as both of us have said, that the nocturnal hypertension is a combination of a cause and effect. Yeah. So nocturnal hypertension could be the result of some condition. In the case of sleep apnea, if you treat sleep apnea, not in all cases though, if you treat properly sleep apnea, you improve blood pressure control, and particularly the night. On the other hand, you have other circumstances where the nocturnal blood pressure goes up for unknown reasons, and that will create a risk for the future. So you may decide you want to treat it, and that is outside any guideline at the moment, but you will use your clinical judgment and see whether the patient has got frailty. They may become hypotensive during the day or may tolerate a moderate treatment. So that is the fascinating part of hypertension clinical management, which still requires a clinical judgment and thinking of. I got one more question here. Shall I do the last question here? Is there a particular drug or regime to avoid extreme dips in the night, but overcome accentuated morning surge? I might try to answer this, and I'll ask Danny as well, but I think, as I said, there is not any specific drug that is licensed or tested or studied in a randomized trial for nocturnal blood pressure only. It is obvious from the studies I mentioned to you that they've done the studies at night and evening administration, that the duration of action is the most important predictor at the moment of the effect at night. So if you give a tablet at 8 o'clock in the morning, the one tablet, for instance, got the longest half-life that I'm aware of at the moment is amlodipine. Amlodipine has a half-life of 32 hours. So it's the only one that goes beyond. The other one that probably, in terms of the ARBs, that's quite long-acting, is telmisartan. But all the others have less than 24 hours action. So it's very important to understand that when you do these studies, you have an effect of day and night, depending on the duration of action. I think I've run out of questions. For good timing, we have answered all the questions so far. I wish to bring this webinar to an end now. I want to thank Danny Schwartz for joining me in this seminar. Thank you, Danny. It's been a very interesting exercise. I hope you find it informative, and I hope you can probably log in the future and review and tell other friends they haven't managed to see it. They would be on the website of Radcliffe Cardiology. I'd like to remind you that this program is supported by Omron Healthcare and with the support of Oxford Radcliffe Cardiology. So let me just thank you, Danny, for joining up. Thank you all. And I say goodbye to you for the next one. Thank you.